You are welcome to this webinar.
Richard, yeah, sorry, Richard, you're a bit low.
Oh, am I?
Yes, you're a bit low. If you could improve a bit.
Is that better?
That's better.
Right. So you are all welcome to this webinar as we commemorate the World Malaria Day on the 25th of April. My name is Richard Marumba, and I work with the Ocular Project as a surveillance and modeling expert. And I'm going to be your driver today. I'm going to be your moderator for this wonderful session. And we're going to start right about now. So malaria remains a significant public health challenge in Uganda and across many low and middle income countries. And while interventions to reduce its prevalence, there are persistent gaps in diagnosis, surveillance, and treatment. And of course, these remain key barriers to elimination by 2030. So emerging technologies, particularly AI, has shown to offer new opportunities to enhance detection, improve surveillance, and optimize intervention strategies, including diagnostics. So this webinar is hosted by the Makerere AI Health Lab and the Malaria Consortium, and it seeks to explore how AI-powered tools can improve malaria diagnosis, strengthen disease surveillance, and support policy-driven and data-informed decision-making. The discussion we're going to have will explore the feasibility, impact, and potential for AI diagnostic and surveillance technologies within low resource context. And with us today, we have a great team of panelists that are well experienced in this area. To start us off will be Dr. Rose Nakasi, who is a computer scientist and artificial intelligence researcher. She's also a lecturer at Makerere University, and she heads the Makerere AI Health Lab. She chairs the ITU WHO WIPO topic group AI-based detection of malaria under the global initiative AI for Health. Her research interests are in artificial intelligence and particularly development of low-cost tools for improved automated solutions for diagnostic health challenges. Rose is currently the project lead for Lacuna SRMH project and Ocular, a Google-funded project that supports automated microscopy of malaria, TB, and cancer. She is the PI for the NIH DSI Malaria Project under the DSI Africa, an initiative to support effective malaria diagnosis. We also have Dr. Alfred Andama, who is the current Chief Laboratory Technician in the Department of Medicine at Makerere University, College of Health Sciences. Dr. Andama holds a Bachelor of Science in Biomedical Laboratory Technology, a Master of Science in Laboratory Science and Management, and a PhD in Microbiology from Makerere University. His current research interests are focused on conducting pilot accuracy studies and usability assessments of novel TB diagnostics and prototypes to inform their further development. He is being mentored by Dr. Aditya Katamanchi, who in conducting TB diagnostics and research. His career goal is to become an independent research scientist in developing and evaluating new lab-based diagnostic tools and serving as lead for novel research ideas, innovations, and testing platforms. We also have Dr. Sam Budoi. He's a medical doctor by training, senior public health practitioner, and is passionate for malaria elimination. Today, he has spent over 2 decades specifically working on malaria control initiatives in the East and Southern African region, working within ministries, NGOs, and academic institutions. He has a wide experience providing strategic leadership and oversight to large-scale programs, implementing integrated health programs, and managing and mentoring diverse teams. Over the years, he has built strong skills in project management, research, and analysis. He has provided technical leadership on universal, long-lasting insecticide nets distribution in Uganda, empowering households with this effective malaria prevention tool. He has co-authored papers on institutionalizing integrated community case management, addressing barriers to intermittent preventive treatment of malaria in pregnancy, and led the feasibility and potential scale-up of seasonal malaria chemo prevention in new geographies of East and Southern Africa. He has attained training from Malaria University of Science and Technology, Makerere University, where he has attained his Masters of Public Health. He is an alumni of the US Department of State International Visitor Leadership Program 2019 for transformational leadership and professional inclusiveness. And lastly, we have Mr. Solomon Umuza, who has served in several capacities at the Ministry of Health Division of Health Information Management, supporting major digitization initiatives aimed at improving the application of digital health technologies to facilitate the attainment of the overall objective of delivering high-quality health services to all citizens of Uganda. With over 6 years of experience in the health sector, Solomon's focus has been digital health in areas of governance, security, research, innovations, and project management within the health sector. He has previously worked in academia, supporting research, focusing on emerging technologies within the telecommunications industry. Knowledge, experience, and practice are related to the topic of discussion this day. And to start us off, is Dr. Rose Nakasi, and she's going to tell us why the need for AI in malaria control. Dr. Rose, you're welcome.
Thank you very much, Richard. And good morning, everyone. I hope, Richard, by your confirmation, you're able to see me and as well hear me.
Yes, I can see you and I can hear you.
Yes, I'm glad to be part of this conversation, especially when we, as a country, but as well as the world, we're commemorating the World Malaria Day. So such conversations come timely, and I'm happy to engage. Thank you for the kind introduction. I should be able to just make a short presentation, and as per the task that I have at hand is to really give an overview of what we are doing here at the Makerere Artificial Intelligence Health Lab in as far as malaria diagnosis and surveillance is concerned. Hope you can see my screen.
Yes, we can see your screen.
Great. So I'm going to be talking about a very passionate topic, and that is on leveraging artificial intelligence for malaria diagnosis and surveillance. Just going to make a simple presentation, And I understand that the bigger part of the conversation is going to be really conversational. I'm happy to be joined by Dr. Alfred, who is the lead and principal microscopist and lab technician on the project. He has been very pivotal in as far as this work is concerned, but also looking at the interdisciplinary kind of panelists on this conversation today from the Malaria Consortium as well as from the Ministry of Health. This becomes a very good platform for us to talk about the emerging technology of artificial intelligence and how we can be able to harness the capabilities of artificial intelligence for malaria control. And I'll be giving a case for malaria diagnosis and surveillance in Uganda. About the Makerere Artificial Intelligence Lab, our work hinges on addressing pressing health challenges. And here we harness and leverage cutting technologies such as artificial intelligence. And we do this by fostering an interdisciplinary collaboration to revolutionize healthcare delivery with an ultimate goal of improving patient outcomes and making a meaningful difference in the lives of the people in our communities. And I'm happy that this is a multidisciplinary kind of panel. So it creates and hinges on the missions of the lab and the reason why we do the work that we do. As I look at the work that we are looking at under the Ocular project and bringing back again the context of why are we utilizing artificial intelligence for malaria diagnosis, it comes back to the public health concerns that we have within our societies, especially the sub-Saharan Africa, where Uganda is inclusive, where we're looking at the mortality and morbidity of the disease currently at 27 to 34% of all outpatient visits, and 19 to 30% of all those inpatient admissions are literally malaria cases. But when it gets down to the way the disease is diagnosed, especially through the gold standard mechanism, and I know that Alfred will talk more on to that, we see a very big human resource challenge, especially around the technical skills in manning the gold standard mechanism of using the microscope. So in the picture here, we see a lab technician really straining his eye to be able to view the small pathogens under the microscope, but also notwithstanding the guidelines that come with WHO that the technicians are not supposed to assess more than 30 to 40 slides in a day. So what that means is that with the high burden of malaria within our context and in our country, you realize that if we are to go by the WHO standards, literally most of the patients would go either without a diagnosis because they usually go beyond the set standards by the WHO, but also by the time probably they get the right diagnosis, probably the disease has gone into dire conditions. And what that then means is that the disease is either not going to be diagnosed timely, or by the time the patients get their right diagnosis, probably they have reverted to solutions such as self-medication or medication based on symptoms, which results in, again, dire outcomes such as drug resistance, which could later actually lead to mortality cases that we are witnessing lately. When it gets to surveillance, again, when you look at the current HMIS systems and the DHI systems that the government relies on, sometimes we've seen that there is delay in the way data is updated or uploaded into the electronic health management system. But again, this is curated sometimes weekly and monthly. So that means that if government is going to take timely intervention, sometimes it will have to wait for that time until they get the right data to route interventions to that. So we're also going to be looking at how can, again, artificial intelligence be leveraged to manage real-time case reporting, but also incorporating other pieces of data sets so that it can support disease surveillance. So what Ocular project is really about is, can we be able to utilize artificial intelligence to support the way malaria is diagnosed to the gold standard of the microscope. So literally we're focusing on developing a decision support, and we really want to call it a decision support because at the end of the day, we really want the technicians to be empowered, to be augmented in their work so that they provide improved accurate diagnosis of malaria. But also under the Ocular project, we're looking at how can we be able to improve malaria surveillance through automated reporting and machine learning based prediction models to support development of robust timely reporting of malaria cases. So in this, what we have done, and the meaning of ocular literally, it means the eyepiece. So we really come in at that point of examination of the slides through the eyepiece of the microscope. And what we've literally done under the Ocular project is that we have developed a 3D printable adapter that is attached at the eyepiece of the microscope to be able to capture whatever is under the microscope onto the smartphone. So with the comfort of the lab technicians, they are able to capture images onto the smartphone because this is in alignment with the focal point of the eyepiece of the microscope with that of the smartphone to be able to capture directly what is under the microscope onto the smartphone. And we've done this collaboratively with the experts in Makerere and Mulago Hospital and the different other health facilities that we're collaborating with to be able to curate a big number of image data sets onto which we now just oppose the machine learning models to learn the characteristics, say for example, of the malaria parasites. In the image you see on the right here is the detections that the machine learning model has been able to make onto the test image after the model has been trained on a good number of objects that are representative usually of the objects of interest. So if we are looking at malaria parasite detection, the object of interest in that case will actually be the malaria parasites. So here we've also gone further to do validation because we want to build models that have been validated by the experts to provide that quality check. Under the white boxes, that shows the expert annotations on the pathogen locations. And then the red boxes you see in that image are actually the detections by the model. So you could see clearly that actually the artificial intelligence model matches closely with the expert knowledge and sometimes surpassing that because here you could even be able to see that the expert, rather the model annotation, the model detection is actually surpassing what the expert annotation on that test image looks like. We've gone further to develop these approaches across, and we want to standardize this one for field-based detection so that we are able to look at the different settings under the fields under which the microscopic images are captured and the different models that are just opposed on these different images so that we create an in-field usable model that can be able to, be utilized in all the different environments. And we're doing this by putting into consideration the kind of environment, for example, what kind of phone was utilized to capture the images, what kind of microscope are we looking at, what are the lighting or resolution of the image that is able to come out, so that we incorporate all that information into the models that we develop to create very usable models in the field. So right here you see is images from the sample image that was captured to the expert annotations and then the model annotations. But again, you could clearly see that the model annotations are really matching up the expert annotations onto the test images. We've gone further to utilize these models across the different malaria diagnostic tasks such as parasitemia determination. For example, in this image that you're seeing right here of a thick blood smear and detections of the parasites, but as well as the white blood cells, which information is actually useful in quantifying the malaria parasitemia. We're also looking into aspects of species identification through the thin blood smears. We are looking into life stage growth detections. And so we want to make the application as wide and with varied tasks that are pertaining malaria microscopy as possible. Around the malaria surveillance model, we do acknowledge the fact that sometimes when reports, especially in the remote facilities of the country, these are usually curated on paper and then aggregated monthly or weekly into the and digitized and then aggregated into the digital health management systems. But what we are proposing under the Ocular project is, can we be able, through the Ocular detection application, be able to, in real time, once the detection is made through the Ocular application, have that record seamlessly, integrated within the health management system, so that there is seamless flow of information from the diagnosis to the reporting into the health management systems, but also augmenting that information with different aspects, because we know that malaria is a vector-borne disease, and that means it survives within an ecosystem. So can we be able to leverage information about the ecosystem and build that into the models, so that we can have robust surveillance models that are very informative, but also are very accurate in context? So we aggregating, and I'm glad that on the panel there is one who is actually working on net Ministry of Health has had different initiatives. So can we be able to incorporate all that information and see how we build that into the surveillance models to be able to generate robust models that are able to inform the relevant stakeholders, especially the Ministry of Health, once it is looking out for, making timely interventions for control of malaria. Again, as we look at artificial intelligence, we come from a society that probably may not necessarily know English, but not alone. Again, we're looking at a society that needs to be communicated, especially communicated to, about some of these emerging technologies. So at the Makerere AI Health Lab, we are thinking, can we be able again to use artificial intelligence to communicate artificial intelligence to the communities that probably for now may not know what artificial intelligence is or what its capability is in as far as malaria control is concerned. So we're building medical machine translations for medical malaria diagnosis, and again, community engagement, so that they are able to know about the capabilities of artificial intelligence and how it can support malaria control. So we are developing chatbots, and these are developed in multilingual, or what I would call different languages within our context, so that patients or people within the different communities who may not know English or who may not know what artificial intelligence literally is, could be able to benefit from the information that comes out of these tools, so that it empowers them to know, but also it gives them sensitization to know about the capabilities of what artificial intelligence can do towards the control of malaria. Would wish to express thanks to our funders. This is just an intro, so thank you very much. I will stop it for now, and back to you, Richard.
Thank you so much, Dr. Rose. Yes, just answering to this question, Shakira Babire, yes, we will work to ensure that we have this session provided. Thank you so much, Dr. Rose. Right about now, we're going to have Dr. Alfred coming. Dear attendees, you will have a time when you're going to ask the questions. So please keep them, write them, and at an opportune time, we're going to invite you to be in position to ask those questions and make the comments. Pardon me again, we're going to have Dr. Sam Udoi, who is the Senior Project Manager, Malaria Consortium, and is going to be taking us through the current challenges in malaria diagnosis in Uganda, after, of course, learning about what AI is capable of doing. Let us look at those challenges, and thereafter we see how we position ourselves and how we fix in the different emerging technologies. Dr. Sam, you're welcome, sir. Dr. Sam, you're welcome, sir.
Thank you very much, Richard, and thank you, Rose, for the introductory remarks. Equally, I am happy that we are sharing this platform with colleagues from the Ministry of Health, and more so with the colleagues from Makerere University, because often when you're in the program side of things, we tend to move separate routes with the academia. So this is pleasing that today we can share the platform and we can all coalesce to see how best we can tackle the issues regarding to malaria control, malaria elimination in Uganda, and of course contributing to the wider malaria control within our neighborhood and within the continent. Thank you, Richard, again for the introduction. And concerning our topic for discussion today, and I hope you are, Richard, the screen is not allowing me to share. The plan was for Daphne to share from that side. Daphne, are you able to share?
Yes, I'm going to share shortly, just a minute.
As Daphne shares, malaria continues to be a major challenge to global health, especially in the limited resource settings and among children under 5 years old. In Uganda, it's the leading cause of morbidity and mortality, indeed accounting for 5% of all malaria cases and 3% of malaria death worldwide. There has been progress in reducing malaria burden, but challenges still persist in achieving strategic plan targets, with barriers to malaria prevention, diagnosis, as well as treatment interventions. Uganda adopted the WHO Test and Treat Guidelines 2010, requiring testing all suspected malaria cases before treatment. But to date, compliance with this guideline is not a reality. So based on our implementation learning, based on data reviews, as well as research studies, there are identified challenges to malaria diagnosis. And in the context of malaria elimination, in the context of our topic today, which is surveillance, I would like us to have an overview of these challenges regarding malaria prevention, malaria in pregnancy, as well as malaria case management. For malaria prevention, one key challenge is really asymptomatic malaria. You will understand that current treatment guidelines emphasize passive case management, which is based on symptoms, fever, and the others. Yet asymptomatic carriers, which is about 95% of the infections, remain undiagnosed. And this therefore presents a pool of a transmission reservoir, which contributes to sustained community transmission of malaria. So this is one area that we really need to examine and see the approaches and see the appropriate tools that we can use to be able to detect and respond to asymptomatic malaria. The other aspect is the surveillance regarding the vector, and that's the mosquito populations, those that are infected with the Plasmodium, particularly Plasmodium falciparum in our environment. Usually the focus is on the damage, it's on damage control. We have focused diagnostic approaches on suspected malaria cases, but not much has been done in ensuring diagnosis of mosquito populations that are infected with the parasite. And this is useful because it helps to estimate exposure to parasite infection, as well as the potential transmission intensity, which is critical for prediction of malaria upsurges and epidemics. Regarding malaria in pregnancy, there is a diagnostic challenge which is related to sequestration of parasites. During pregnancy, parasites tend to sequester in the placenta, and peripheral blood smears are usually less sensitive, and there is potential for asymptomatic infections among pregnant women. So this, is a critical contributor to the challenges associated with the pregnancy and the baby. Our main approach to malaria diagnosis is the use of the rapid diagnostic tests, but again, their sensitivity and specificity for pregnancy-related malaria may be suboptimal, and therefore there could be misdiagnoses and the proliferation of the undesirable consequences related to malaria in pregnancy. And then there are also challenges in the antenatal care. Some pregnant women may not seek or receive adequate antenatal care, including malaria testing. And this usually has the effect of delayed diagnosis and treatment. In terms of case management, there are inadequate healthcare resources, especially regarding staff in light of their skills and of course numbers, but also the infrastructure, which limits timely and accurate diagnosis of malaria. We have also established that the supervision and its coordination of the health workers and their practices indeed impact quality of care, including malaria diagnosis. And then critically as well is the aspect of drug resistance, which is really emerging. And this is challenging in the sense that it poses difficulties in differentiating between malaria infections and the other, differentials to malaria. And therefore, we need to think about which tools are effective for diagnosis of malaria in the context of drug resistance. And then, of course, we have geographical barriers, which limits access to diagnostic services, and then the socio-economic inequalities, where communities are unable to pay for diagnostic services, especially in the private sector. Indeed, an evaluation of private sector anti-malaria sales revealed that only 25% of the clients visiting the facilities were able to procure a rapid diagnostic test, meaning the 75% got malaria treatment without a malaria test. And then we also have cultural beliefs where suspected malaria is perceived and interpreted based on these beliefs. And these in themselves hinder access to diagnostic services. So the initiatives, one of the initiatives at Malaria Consortium to really improve patient care and to pilot available technologies for service delivery was a digital health project in Buikwe. And this project aimed to digitize village health teams to improve their service delivery capabilities, including reporting of diagnosis and treatment services at the community level. Now, this fits into the Ministry of Health electronic community health information system, as well as the guidelines. And the multiple stakeholders at all levels were engaged, and the implementation was within the existing structures where provided training, sensitizations, and regular support supervision, as well as regular performance reviews. And then a baseline and end line was conducted to provide evidence for potential scale-up of this project in the country. So from the evaluation using a mixed approach, both quantitative and qualitative data collection methods, and the data was from the DHIS2, incorporating the electronic community health information system, enabled gaining insights and reach of the project in Buikwe district. There are also qualitative interviews, basically key informants, as well as focus group discussions. And then really from the quantitative and qualitative insights, we determined 5 key impact areas. One is that the digitization of the village health teams really increased their empowerment. And then health outcomes also improved because prevalence of malaria as well as pneumonia in the area reduced. There was also improved health seeking behavior from the community members. And then reporting was enhanced, and this was in real time because the digitization linked directly to the electronic community health information system of the Ministry of Health. So every stakeholder involved in the project was able to visualize the data and the necessary action taken. And then there was also improvement in the community trust and the engagement because there was fostered participation at all levels. These are some of the feedback from the qualitative insights. And we took lessons from this project. And one was that the VHTs were able to use the digital tool, and even 2 languages were actually sufficient, English and Luganda in this case. And the digitization was actually an excitement for the VHTs, and this motivated them, and they are very willing to onboard any new initiatives at their level. And probably this could include the AI. There was a positive environment, meaning that communities really are open to welcoming new initiatives, especially when they are engaged. And then already I shared that prevalence reduced, and therefore this translated into reduced OPD visits, and indeed even severe malaria cases reduced. Continued training and supervision is key to these new initiatives, and it should also be able to leverage existing opportunities. And our learning here was that the ongoing, national campaigns gave the VHTs the confidence to understand that the project was within the national framework. Of course, there was because this was a digital tool, there are some challenges relating to system downtimes, and sometimes this affected the data transmission. And the lesson was if there was any system downtime, we needed to communicate this in advance. So based on the challenges highlighted under malaria prevention, malaria in pregnancy, as well as case management, and the lessons from the WIGWE digitization project under Malaria Consortium, we make some recommendations. And one is there is need for regular HMIS and ECHIS reviews. And specifically, they should increase the use of the electronic community health information system data for surveillance, and then overall program decision making. We should establish sentinel sites for vector surveillance, including surveillance of mosquito populations for Plasmodium infection, as well as anti-malaria resistance tracking. We should explore innovative diagnostic tools across board, not only case management, but prevention, malaria prevention as well, such as AI. And then we should also consider the rapid test for Plasmodium infection in mosquito population, so as to bridge the gaps and the challenges that we have highlighted. We should provide regular supportive supervision to health facilities, including which really translates into improved resources and coordinated efforts. But indeed, more critical is even the dissemination of the supervision reports at different levels to foster action. Finally, we should focus resources on training and mentoring health work of the diagnostic tools existing and those new initiatives like we are discussing today. Thank you very much for listening. Over to you, Richard.
Well, thank you so much, Dr. Sam. Quite insightful and informative. And we are still moving on. Louis Cook, you have a hand up, but we have a session for questions, for comments, right after our presenters. So kindly be patient with us because we have an entire session for that. Let us have our presenters finish and then we will have a full session entirely made for that. Thank you so much. So right about now, we are going to have Mr. Solomon Muhumuza. Please come on and discuss with us, share with us your expertise and your experiences. Thank you so much, Mr. Solomon.
Yes, I hope I'm loud and clear.
Yes, you are.
Yes, quickly, in case my network drops, just let me know. In previous engagements with the teams here at Ministry of Health, the National Malaria Elimination Division, and partners working around this space, the questions were how do we align AI tools with the Uganda malaria elimination strategy. The first thing is that the strategy itself does have a provision for use of digital tools for the fight against malaria. However, the strategy of how we utilize digital tools like AI is further detailed in the Health Formation and Digital Health Strategic Plan for Uganda. And this plan entails how we are going to introduce new technologies. And specifically, if you look at Strategic Objective 6, it looks at how we are going to use research and innovation to be able to introduce tools through informing policy and strategy development. So we have to leverage research and innovation to be able to influence policy and strategy to the level that we're able to influence what is within this strategic plan. To mention, as a country, we have an overall Ministry of Health strategic plan that guides the entire sector on how best we're going to implement various interventions. And that plan will be coming to the end in June, at the end of June, and we shall be starting another plan. So right now would be the time for the different stakeholders to engage Ministry of Health to ensure that overall there are provisions for AI tools that we can use. And also this would further influence all the other plans. For example, the malaria elimination plan, the digital health, and the Health Formation and Digital Health Strategic Plan are all drawn from the Ministry of Health Strategic Plan, which gives priorities. And it's not just priorities, but also we go ahead to cost and budget. And this would definitely inform on how we scale these tools using resources. So it is very key that we have that catered for. The other thing would be, of course, we should be thinking about how best do we adopt AI models for purposes of affordability and scale in low resource settings like Uganda. As a country, we do have limitations in infrastructure. We have limitations in the human workforce. We do have limitations in, of course, in the different tools that we use because we don't have a lot of resources. And therefore, as a country, the strategy should be, we should be prioritizing high impact low cost use cases. So we should prioritize and identify these use cases. As Dr. Rose was presenting, the malaria diagnosis and surveillance use case is one excellent use case that we can start with, but we need to also tease out the ones which we can prioritize. We can't do everything because of the resources we have, but the malaria diagnosis and surveillance is a very good one because looking at the number of children below 5 who are dying from malaria every day, this specific use case would significantly improve the health outcomes. She mentioned about the one for the surveillance within the community or within the facilities. It would also be very key looking at the number of outbreaks that we have. Next, I think one of the things we should be making considerations for is to choose lightweight offline are capable AI models. As a country, most of the tools we've rolled out at the community level, at the health facility level, are offline fast tools that we use because we don't have a stable internet connection to ensure that the different tools are able to query a central database. So the strategy should be that these specific AI models that we are designing are able to run on devices, on end user devices, whether they are mobile phones or whether they are computers at a health facility, therefore leveraging edge computing. So that is very key. Looking at the strategy, I had Dr. Sam talking about the electronic community health information system that we deploy in the country. It is an offline fast system. And therefore, if you're going to implement models which will need consistent or constant internet access, that is going to be a problem. And the other thing I need to mention, that is the third point, is we should consider integrating AI tools into existing digital health platforms. As a country, we suffer from the replacement mentality, system replacement mentality, because this tool we've had for so many years cannot do XYZ. It should be replaced completely. We've seen proposals from our partners, from our technology partners, to replace some of the tools because now the tools they have some AI capability. That is not going to happen. We've been investing for years in these specific tools. We should be focusing on improving these systems and therefore looking at which modular AI components we need to embed in these systems to improve the performance of the systems rather than replacing these systems. And lastly, we need to localize the data and the models themselves that we use. And I had Dr. Rose submitting. We need to train and fine-tune the models within the systems that we use, given the context of Uganda. I know most of them are some of the models we see are being built based off data sets which are foreign to this context of the country and may not be so accurate or may need a lot of work to be able to contextualize. We do have the data, and I had Dr. Rose talking about that. We do have a lot of data, whether it is to do with samples for malaria, HIV, different, even if it is TB. We have a national laboratory where all these samples are archived, and we could definitely utilize that valuable data to be able to train these models. And speaking about AI in health, there are very many challenges that we face as a country that we shall need to overcome to be able to expound or to be able to take advantage of the various benefits that Dr. Rose talked about. One of the challenges we have as a country is a fragmented health information system. There have been efforts in the past 3 years to bring the systems together, but still, for example, we only have the ECHIS integrated with the DHS2 for reporting, but it's not integrated with the electronic medical record system at a health facility level. So there is a lot of work that we need to do around that to be able to leverage the benefits of these tools. The other one is poor compliance to legal and regulatory frameworks. For example, we have the Data Protection and Privacy Act that is in place. And within the Act, you need special provisions to be able to host the data outside of the country. So that becomes a challenge to have some of the models which have to run out of the country. That may not be optimized. That is something that we need to think about. But in terms of also compliance, when we are introducing these tools, there is a certain process that Ministry of Health has set. It is very key that this process is followed so that we are able to get the benefits. In the past, we've seen there are tools which have been deployed, but have largely been partner-based tools that when funding is discontinued, these tools have died out. The issue of inadequate infrastructure is a very big challenge, and it remains a very big challenge. And that's why I said we need to build tools which are able to run on the existing infrastructure that we have in the country. And the other one, lastly, is the issue of digital literacy. we've struggled. The health workforce, as they were being trained, did not incorporate the use of ICTs in their work. So as we roll out digital tools, we have to go backwards and be able to train these individuals on the use of ICTs first before we train the health workforce on the use of the digital health tools that we want. So there are a number of challenges that we need to address and overcome to be able to leverage the power of AI. But what I can say overall is that having a national artificial intelligence implementation framework for the country is key. We've started those efforts. It will be able to guide on how we access data, for example, for training of these models, on how we introduce new tools that are based on these AI models, on how we do the testing, on how we develop in-country capacity. Capacity is one of the biggest things, which is very critical to ensure sustainability. So within that framework, we shall be able to address issues of sustainability. We've seen technologies introduced in the past, but they're not, they leave their project based. When the project ends or the funding ends, that's where the benefits stop. So as I conclude from the government perspective, our efforts right now is first having a national AI in health implementation framework, and this would further guide the introduction of the different tools which we are seeing. At the moment, we are doing research within Ministry of Health based on AI. There are some innovations we're doing on a very small scale to just inform the framework we're working on. But there is a lot of pressure from partners, from innovators to be able to take on their tools. We've been working with Makerere AI Health Lab and WHO, the World Health Organization, on this particular framework. And we think once it's up and running, then we shall have better implementation and realize benefits from this specific technology. Thank you, Richard, and back over to you.
Thank you so much for this wonderful presentation, Solomon. Yes, quite a number of comments are coming in, but I'm going to them in just a few. I wanted to highlight a few things on my side. I know time is not our best ally right now, but I just wanted to highlight a few things as well. And there is a question that speaks to partnerships. Why are we even talking about partnerships per se? Why do we need them? Now, the 2017 midterm review of the UMRSP indicated fragmented planning and implementation. And as a matter of fact, actually, Solomon here has also highlighted or has hinted on it, that there is fragmented implementation, and this, of course, affects reporting. And so one of the ways to overcome this is partnerships, collaborations. Okay, so of course, as a result of that report, we see that the National Malaria Control Division started improving its working collaboration with MOH departments, but also other ministries, departments, and agencies who are partners, okay, in the quest to eliminate, malaria, but also community structures. And the major point here is, number one, to, of course, to foster collaboration, leveraging on everyone's, strength, but also complementing, and filling in the gaps where weaknesses are. Number two, resource sharing, expertise exchange. And I'm going to give a case study here regarding, our context, what we're talking about. The Makerere AI Lab is working, of course, in collaboration with WHO, the Ministry of Health, to ensure that we have the national integration in AI framework, just like Solomon has highlighted. So, but we have an exchange of experts from the artificial intelligence side to the clinicians, but also to the policymakers. And this, of course, improves at the end of the day practice, but also policy development, but also government, of course, coming in the private sector. Of late, we have quite a number of players in the AI field that are private, and they're coming in as well. But also international organizations. We're talking funding. We're talking again expertise, leveraging on expertise from colleagues, without or abroad. And so, at Ocular, we're talking about a diagnosis, but also surveillance. And surveillance is one of the, of course, the outputs or one of the components of this project. And just like Dr. Rose highlighted, we propose a complementary framework. And this is going to bring out the element of partnerships and collaborations. And that's why I'm using it as a case point. We propose a framework that will inform integration of machine learning components to the existing system for effective surveillance, disease case identification, but also for prompt interventions. Dr. Sam talked about some interventions that have been done, especially moving digital, but also Mr. Solomon here also highlighted a few digital platforms that have been put in place. And we are saying that, can we work together? Okay, can we come together and integrate this and probably apply ML, machine learning, to get the best of all these platforms? And we're saying once we do this, we're going to improve integrated disease surveillance and response, of course, starting from malaria, but then opening up to others. And this, of course, will enable reliable and real-time reporting for effective surveillance of diseases in selected regions for prompt disease interventions. And in here, when we look at our framework, we have a number of levels. For example, at the health facility level, we're talking about automating patient registration. Of course, a bit of that has been done, but we want, Solomon highlights, offline, applications as ideal, most especially in, hard to reach areas, so to speak. But we're talking automating this process, but also case reporting, combining that with laboratory testing. Okay, so automated data capture. But we're talking about the natural language processing techniques that can extract relevant information from clinical notes and other textual data that aids to identify potential disease, okay, or even cases. We are talking about ML-aided dashboards for visualization, even at the health facility level. Then at the district level, we are talking about, collecting surveillance data from health facilities. We're talking about timely reporting, alert systems, having alert systems, but also recognizing patterns and anomalies in health data, okay, from both consultation reports, pharmacy reports, and other health records, even at the, the different laboratories. At the national level, we are talking about predictive modeling, information dissemination, and policy formulation, which we are currently engaging in. Now, at all these levels, there is a sense of partnership, there is a sense of collaboration, there is a sense of coming together with one goal to ensure that we implement AI to improve, of course, diagnosis from the health facility level, but also all through data collection, dissemination, and aiding decision-making for surveillance. So that is an important component. You know, and we can only achieve that once we have those partnerships going. But even as we're talking about all this, we have barriers, and some of these we need, of course, a multidisciplinary approach to handle this. Awareness to the availability of these different tools, AI tools, ML tools, even applications. How aware are we? Some of us who are in these circles, the AI circles, the lab circles, probably the policy levels, MOH, Malaria Control Division, we may have a sense of knowledge of what is happening here. But how about that clinician who is in Makerere, for example? Do they even know that there are such tools that are going to, to help them quicken surveillance, but also look at the accuracy of the diagnosis they are doing, but also surveillance? So we need to find a way of, providing information and awareness, most especially for the tools that we're even thinking of bringing on board to improve healthcare. We have ethical concerns. So some of these tools, especially the models we're talking about, they involve a lot of data collection. But have we sorted the concerns of, the data that we're using, the patient data that we're collecting? Who else is looking, even where we keep this data? So we need as well to come up with frameworks that are going to deal with such concerns. And of course, for some of us who have been in this, have had this challenge in line with ethical concerns. I mean, you write up a proposal, but then it takes ages to be approved at the different levels of ethical approval at our regs, okay? And, the members there are examining every detail. I'm not saying that it's bad, but my point is, sometimes we end up taking a lot of time. And fact is, most of them are not, there is some human resource gap, especially when it comes to this daily evolving field of AI and ML. And so we need to create capacity as well there, or, as, different disciplines coming together. So, but then the infrastructure support AI. Maybe Solomon, one other, later can tell us if there are any infrastructure that has been put in place at even, the lowest level, because in malaria is screened from even, the lowest level, 0 center 2, 0 center 3s, from using the strip to, microscopy and all that. But do we have these infrastructures? So that is, and these are things that we can look at, and we have to approach these challenges with health, with the systems thinking. We can't go on, pointing fingers. So and so has not done this. So and so has not done this. We need to come up with a systems thinking and a systems approach to ensure that we work on this and provide solution to this. Lastly, we are glad that at the AI Lab, we are partnering with WHO and MOH to come up with the national policy. Will be of importance, most especially if we are going to move together, most especially if we are to have a successful implementation of this. Yeah, that's what I wanted to communicate here. Right about now, I would love to open it up and have some questions and answers, I'm going to request that someone puts up their hand and then we select them. Please keep the comments, the questions brief because we don't have much time. Thank you. Let us start off with Louis Cook. Please be brief, straight to the point, and then we have response. Thank you so much. Louis Cook, are you there? Okay, as she prepares to come. Emily Godwin, I'm wondering about the cost effectiveness of the ocular diagnostic tool for identification of parasites. Has there been some analysis on the cost versus the sensitivity of the diagnostics? And what does the increase in parasite detection actually mean in terms of clinical diagnosis? Were there cases where a person could not identify a malaria infection, but the tool could? Rather than just picking up mere parasites on a slide, how much is the tool and how much would introduction cost? That is to say, training, required linkage, and how much would linking it to data collection tool to enable real-time reporting cost, this would be great. I'm going to request Dr. Rose to attempt the first part of this question. And then the second part where Emily asked about what does the increase in parasite detection actually mean in terms of clinical diagnosis to Dr. Alfred. So Dr. Rose, the cost effectiveness of the ocular diagnostic tool, any response?
Thank you, Richard. And thank you, Emily, for that interesting question, because it's a question that addresses the value proposition of ocular. So we're looking at the value proposition in different angles. One, we're looking at the value proposition in terms of, in a day, how many patients can one technician be able to, diagnose versus what the ocular tool can be able to support against the different limitations. Away from the WHO guideline of only 30, I don't know if there is some. Thank you. I think now you can hear me well. Away from what the WHO guidelines are against what a given technician can be able to view in one day is just 30 to 40 patients in a day. And where that comes from is the process it will take a technician to be able to, analyze the entire slide to give a diagnosis will literally take them not less than 30 minutes or between 30 minutes to, 1 hour, basing on a given task at hand. If it's just looking at the parasites, literally what that means is that if we have a big negativity rate, before a technician, clears a patient for malaria negativity, they have to view not less than 100 fields of view to ascertain if someone is actually malaria negative. So what that means, if you just oppose it against time to have a technician look out into the microscope for all those 100 fields of view, that will literally not be something less than either 30 minutes or above. What does the ocular project, in terms of timelines, in assessing a given slide look like? We're looking at literally less than 2 seconds to be able to analyze and give a clear count of whatever has been detected under the sample. So if we to just oppose that against the expert and the time that it takes the artificial intelligence tool to detect against what the expert how much time it's going to take them to provide a diagnosis. Again, in terms of time, you're able to see a value proposition that comes with the artificial intelligence tool. When we get now to the cost of the setup, because what we're talking about is that, of course, we're looking at a microscope, and we are supposing that almost at every public health facilities up to level 3, there is an existing microscope at those different health facilities. So what we come in with is, can we be able to have a printable adapter, which literally will take less and then this is plastic, and then we're looking at a basic smartphone. So vis-a-vis the impact of the technology and the number of patients that are going to be analyzed through the system, when you compare that with what is currently existing, I think you see a very cost benefit of the ocular technology against the existing platforms.
Thank you so much, Dr. Rose, for that response. Yes, Dr. Alfred, please have the floor. Please unmute. Dr. Alfred, unmute, please.
Sorry. Sorry. I was just thanking the previous speakers. Maybe, I don't know, you wanted to start with the question that you already had for Rose, the first part. Quickly, just to say is that the question was about the level of parasite count, and that relates to detection and probably management. But what I would want to say about that is the higher parastemia has different use cases in clinical care. One, it can give information about how severe that malaria is. Sometimes when high parastemia, a lot of complications come early. Then it also guides the clinician on the choice of treatment. In higher parastemia, sometimes they consider, and already when the complications already setting in, they can choose a different line of treatment depending on how the patient behaves. Then the third thing is response to that treatment. When you start a patient on the malarial treatment and you test it, you test the patient again, say using microscopy, and the malaria parasites are still there in the numbers that were initially diagnosed, then you can have a sense of probably the treatment is not effective, or the parasites in question showing resistance to the treatment. Yeah, so it is an indicator of drug resistance. So coming back to my presentation, it was all about the role of AI in the malaria diagnosis and surveillance. I think, Richard, you have talked a lot to the surveillance part. Maybe briefly, let me talk about the diagnostics and building on what Rose already presented. These are the questions I was asked to talk to. That's how does AI improve malaria diagnosis, and introduce the ocular AI tool. The key phases in the development of the tool in the context of Uganda, and the lessons that we have learned in the pilot field studies. Then I thought about how do we move forward. What is the most important on this slide is that this study, which was done by Chiwanuka and the team in 2020, when they found that about 50% of lab technologies in positions where they were supposed to be were not there. And this was also the same case, even much lower in regional referral hospitals. Although they also reported that there was an excess of lab techs in the lower health facilities, these were not the hierarchy supposed to be there. For example, when we moved around the country, we actually found that you may find where you're supposed to have a lab technologist may have a lab assistant with their own capacity to be able to do diagnosis. So that was the difference. Then in terms of, we were already informed that RDT, structured malaria diagnostics, now have been rolled out in different levels of health facilities. And these usually take about 15 minutes to give results. The gold standard, which is malaria, microscopy, takes on average 25 to 30 minutes. But the AI tool that we're developing and testing in the field could reduce that time significantly, because within 60 seconds, you're actually able to get your results on detection and in a quantifiable way. This app has been developed based on our particular situation. This particular graph here shows the relative distribution of different species of malaria. And you can see the other species other than falciparum contribute only 3%. 97% of the malaria species we have in Uganda by 2018 were predominantly Plasmodium falciparum. And so the model, right, as we do it, we test it out, we are sure 97% of the detection will be towards falciparum trophozoites. So the ocular, the primary aim, like it was already mentioned, was to support the techs to be able to locate parasites. And we also know there are a lot of technologies that already spread downstream. We have a lot of microscopes along the line. They may not be the same model. And when we moved around, we also found that most of these technicians have a lot of smartphones. Actually, there are so many smartphones within Uganda. They might vary in different qualities, but generally we have these to leverage. And the technology is very simple. Like Rose explained, the microscope is there, the smartphone could be there. What you need is a 3D printed adapter, which should be able to fit the camera, align it with the eyepiece, and that aligns it with the microscope lighting system, which goes onto the focus field of focus. And so the output of this is like the quantitative detection and WBC count, which is actually a measure of parasite density. So basically, this is the arrangement you can find at the AI lab. The adapter, the microscope, and the phones, and that's what we move with to the field. Now, in 2014, this idea was conceived at the at the College of Computing. So the people that time moved across to medical school where we are based, and we had conversations on how AI could be applied in health. We profiled different diseases, and we knew a lot of malaria was happening here, especially in the acute care unit of Mulago. So we asked for a waiver of consent from the IRB, which was granted. And that's when we did the initial studies. Then later on, we got an extended waiver to go to the different facilities from the Ministry of Health to be able to introduce the project and really support from those managers and staff. So during these phases, we assessed infrastructure and that we would leverage in the subsequent visits, and also prepared psychologically the managers and the lab techs for the next phases. And we used the Ministry of Health regional mapping to identify different regions and the facilities therein to be able to visit. And we had groups that moved to different regions, and at least went to each of the hospitals in this map. Yeah, so when we reached there, we had a meeting with the managers and the staff, and we allowed the facility lab staff to do the routine testing. And in between, as part of QC, quality control, we were able to prepare additional slides, stain them with the traditional stains in the facilities. And also we had standard stain of Jamesha to do the staining on our side. Now, we're able to demonstrate to them how the app works with using the Microsoft that they had, and in case they didn't have, we would be able to display using ours. So we collected their stained slides together with what we stained and moved with this to the AI lab for further image capture and expert annotations. And this, I think, picture, the lower picture on the left, was already explained by Rose. It's really the bounding boxes around the trophozoites and also the white blood cells, and that translates into the quantitative display of those numbers. Now, we realize that malaria sometimes is just more than what we see on social media, because we're able to see children from school missing classes because they were just waiting by the lab side, very sick, say a mother with children, all with malaria, and they could not do anything useful in their homes. And the other issue was the tech shortages. You will find that you can find maybe up to 5 people working in the lab, but 4 of them will tell you we are volunteers because we have not been formally absorbed. And you can now doubt the competency of these volunteers, whether they duly qualified and so on. So the health managers, together with other staff, all embraced the idea of AI-based support systems that can be able to support malaria control in the communities. And facility managers were willing to allow subsequent implementation phase to use existing infrastructure, and only if it was restricted by the implementation partner. We have those kind of cases. You see, this is delivered, say, by maybe Department of Anatomy, for example. It doesn't allow somebody from pathology to use it. We have those kind of cases low in the lower facilities there. And so we thinking of the way forward, given that we are in an endemic area where different species could be available, there's need to curate additional data, especially in terms of images, to increase the detection range for different parasite species and also the developmental stages. We want to consolidate the different model components that have worked well and gather information from the field, either from feedback or from observations, to see how the model can be adjusted to respond. I think this was Solomon's question, how robust this system is. In other words, it shouldn't be something you use today. When you get another type of microsource, you throw away. So it is, I think, easier that this app and its accessories should be adjusted at the development phase in order to fit the infrastructure that is in existence. And we need to continuously, and we have seen this during these recent visits. Although there's a lot of malaria research going on out there, sometimes the smears and the staining quality is really wanting. So probably if funds would allow, and for any other partner that's working on malaria, to be able to go into their research and also do kind of on-site training for the lab techs. Because this app can only work better if we standardize the smear making, the staining, and the examination, of course, focusing will really be something that would help develop and make it deployable a lot faster. Thank you so much. And these are the same partners. And I would like to thank Rose really for bringing all these different partners together to try to answer this particular question, which is lingering all over the place. Thank you. Back to you, Richard.
Thank you so much, Dr. Alfred. Quite an expounded presentation, informative, and really knowledgeable. Colleagues, there are quite a number of comments in the chat, but we've run out of time. Even as we wind up, I would love for you to please visit the social media platforms of the Makerere AI Lab, even as they have been posted in the chat. A lot of information is posted there, but also information on upcoming webinars, conferences, where we can always, discuss and exchange ideas to ensure that we improve the healthcare at large. Right about now, I'm going to call Dr. Rose for parting shots, really, and then we summarize this up. Dr. Rose.
Thank you very much, Richard and fellow panelists. Such an engaging discourse and a very pertinent public health challenge that we're facing, not only here in Uganda, but across the sub-Saharan Africa, and that's the challenge of malaria. And every brick, every addition that has a team, when we come together, like we've come together today to have conversations on how we can control malaria, not just around diagnostics, not just around surveillance. It's a very broad topic around treatments. There is already a challenge that Dr. Sam shared about drug resistance. We need to engage one step at a time to be part of the solution that will end malaria. And I know that Ministry of Health already has a goal to achieve malaria control, that is by 2030. So we, as Makerere Artificial Intelligence Health Lab, we are still committed to utilizing artificial intelligence to support in any way that we can malaria. Again, additionally to that, these conversations, we want them to continue. In September, we already have an Artificial Intelligence in Health Africa conference where we, again, shall be engaging with different stakeholders to widen the conversation. From the team here and to our partners, Malaria Consortium, Makerere College of Health Sciences, and the Ministry of Health, we say thank you, and let's keep in touch as we commemorate the World Malaria Day. Thank you, and bye for now. Back to you, Richard.
Thank you so much, Dr. Rose. Please, everyone, go to your chat and follow the link for the conference, because we need to continue the discussion. You do realize that there is literally little time here, but let's follow the links provided. There is one for the conference, such that you get to know what is happening. A recording will also be available, and you can do this by registering your interest as well for the same. Thank you so much, dear panelists. Thank you so much for your time, your valuable insights, and we hope to see you again as we continue to ensure that we improve healthcare in this country. Please follow us on X at AI_HealthLabMark, at LinkedIn, AI_HealthLabMark. There is a lot of information that is shared there. Thank you so much, and see you soon.